Hello and welcome to our lecture about hypertension drugs. In this lecture, we're going to talk about the physics and the physiology behind hypertension. We're also going to talk about different drugs that are used to treat hypertension. And in addition to that, we're also going to take a look at certain drugs that are used to reduce the symptoms of heart failure. Alright, let's talk about hypertension physiology. As you already probably know, hypertension just means high blood pressure. And pressure is at the basic level just a force over the area. So there are two ways that we can reduce the pressure that is being exerted on our arteries. That is by either reducing the force or increasing the area that is being exerted on it. And there's two different ways that we can do that. One way is that we could reduce the pressure that comes from the volume of blood. That's going to be reducing the force, or the force exerted by the blood. We can reduce the amount of volume or the amount of flow of the blood inside of our arteries, or we can make the arteries expand, and that increases the area. So we can make the vessels expand, and it'll increase the area. Increasing the blood pressure can occur through one of those two areas. Now, our body has mechanisms for maintaining blood pressure. Blood pressure is important to stay high because it helps with perfusion to your body, but sometimes that gets a little bit out of control. Those two main systems is going to be the renin-angiotensin system and the sympathetic nervous system. So let's talk about the renin-angiotensin system. Angiotensin first starts off as angiotensinogen. Now, angiotensinogen is released from the liver, and renin, which is released from the kidneys in cases of decreased perfusion. So decreased perfusion to the kidney most of the time for a healthy individual just means low blood pressure. So what happens is the kidney releases this renin, and renin is an enzyme that turns angiotensinogen, the inactive form, into angiotensin 1. Angiotensin 1 then uses the enzyme ACE, or angiotensin converting enzyme, to turn it into angiotensin 2. Now, angiotensin 2 is a very strong factor here in the process of increasing blood pressure. Has several effects. It'll go to the adrenal glands and it will release aldosterone. Aldosterone causes increased salt retention or increased salt reabsorption and increased potassium excretion in the distal convoluted tubules. And this overall increases the volume of the blood. And increasing the volume means that you have an increase in the force, increases the blood pressure. Sympathetic nervous system can stimulate using norepinephrine, the alpha and beta receptors, and this causes constriction of the vessels in the myocardium. So it pretty much makes your heart beat faster and makes your vessels become tighter. This increases the tension and the pressure by reducing the area. So we've got a reduction in the area over here. It also goes directly onto the blood vessels and it causes them to constrict. Finally, it also affects the pituitary gland. You'll learn more about that later, but just know that the pituitary gland secretes a hormone called antidiuretic hormone. This antidiuretic hormone prevents you from peeing. So what angiotensin does is it stimulates the pituitary gland to release this, and then you just can't release water anymore because you've got these aquaporin 2 channels that help you reabsorb the water in the collecting tubules. So what that means is you just have an increased force because you have more blood that's being retained in you, and that means you have higher blood pressure. Diuretics are an effective way to reduce hypertension. As we've talked about before, one of the ways that we can reduce hypertension is just reducing the amount of blood that is exerting the pressure. And this will be covered in much more detail in the renal module, but as of now we're just going to learn a couple of important diuretics for the cardiology module. One of the most important ones is going to be thiazide. Thiazide diuretics usually have the thia in their name. For example, the most common one is going to be hydrochlorothiazide, or HCTZ. And these ones inhibit the sodium chloride pumps in the distal convoluted tubules. So if this over here is the glomerulus and here's the proximal convoluted tubules, here's the distal convoluted tubules. And what they're going to do is they're going to prevent the sodium chloride pump that helps you reabsorb and retain sodium chloride. So what that does is all the sodium chloride is just peed out and it's not inside of your blood. So because it doesn't go inside of your blood, you get less blood. So you get less force exerted on there and you get a decrease in blood pressure. All right, and this is the first line treatment after you've tried diet changes and exercise. Another one that's also very commonly used is the loop diuretic. These are one of the example. The most commonly used one is furosemide. Now these inhibit the sodium, potassium, chloride pumps. So here's what it pumps right here, and here's how it does pretty much the same effect as hydrochlorothiazide in that you've prevented the reabsorption of the salts. So what that means is more of it gets peed out and less of it is used to increase your blood pressure. So it reduces the amount. It's also known as the water pill, just in case you get into third year and a patient tells you, oh yeah, I'm using the water pill. It's called a water pill because it makes you pee a lot. I'll try to think of it as furosemide makes you pee furiously. And it's especially useful for heart failure because heart failure, the heart is working really hard against a whole lot of blood pressure and it just makes it worse. You could significantly reduce the amount of blood pressure in this case. Let's talk about Aliskirin, which is a new drug. It's not very high yield, so I'm going to go through it very quickly. I remember that the RIN over here stands for renin, and it pretty much inhibits renin directly. So here's Aliskirin, and here it is inhibiting the renin angiotensin system right at the beginning, and it pretty much prevents all of this over here, making it difficult for your body to increase the blood pressure. Now remember that this is a very new drug and it is very expensive, so it's not very often used as of now, but it may come up in very low yield questions. And there's some early studies that are showing that it could be more harmful than ACE inhibitors, so it might be thrown out altogether. Who knows? The major adverse effects here is going to be orthostatic hypotension for the first few days until the body adjusts to the lower blood pressure. ACE inhibitors are probably one of the most used drugs around, period. One of the more common ones is going to be lisinopril, but I want you to look for any drug that ends with opril. This is actually named after Dr. Opril, who works at UAB. So any drug that you see that ends in the word opril is going to be an ACE inhibitor. Their mechanism is exactly what their name tells you. It actually works by inhibiting the angiotensin converting enzyme, i.e. ACE, and this prevents the production of angiotensin 2, one of the strongest vasodilators, actually the strongest vasodilators that we have in our body. This prevents the salt and water resorption and reduces the blood vessel tension. Now, it's actually been proven to actually increase the life expectancy of patients with diabetes, or i.e. kidney disease associated with diabetes. So it's very, very important that if you see a vignette that says that this patient has a kidney problem and he's got diabetes or something, you give him an ACE inhibitor because it'll keep his kidneys safe. This is one of the most high yield questions that shows up on step 1. Now, the adverse effects of ACE inhibitors is going to be similar to any real drug that reduces blood pressure, and it's orthostatic hypotension. Your body needs a little bit of time to get used to the decreased blood pressure, but it has a unique side effect of causing coughs. This is a very common asked question because of how unique it is. Now, something that you need to know is that the ACE inhibitor ACE, or angiotensin converting enzyme, is actually also important for breaking down bradykinins. So these bradykinins are inflammatory chemicals that causes you to cough, especially when you're sick. Now, naturally, they don't really build up a lot when you're healthy, but if you're inhibiting the ACE, they're going to build up a lot more, and you're going to feel like you've got a sore throat or you're always coughing because there's no enzyme to break it down. Now, angiotensin receptor blockers are pretty much the same effect as ACE inhibitors. Instead of inhibiting the ACE, what they're going to do is they're going to inhibit the receptor over here. So they pretty much prevent it from getting further than this point. They all end in sartan, so it's very easy to remember them. I look at this and I think of AR, angiotensin receptor. TAN usually means inhibitor in this case, or an antagonist. So the mechanism is that they inhibit the receptors and they prevent the effects of angiotensin 2. They have pretty much the same exact effects as ACE inhibitors, and this is often used when patients cannot tolerate ACE inhibitors. So the same adverse effects as ACE inhibitors is that orthostatic hypotension. Although you don't see any cough, because that is one of the most common ideas presented in NBME tests, is a patient comes to you after taking an ACE inhibitor and he's coughing too much, what do you give him instead? And you'll look for an answer that has a sartan at the end of its name. Aldosterone blockers, you need to know two of them, spironolactone and eplerenone. They end in O and E, just to remind you that they are steroids. That means that they have an intracellular receptor and they are fat soluble. So they go intracellularly and they block aldosterone's intracellular receptor, and this prevents the effects of aldosterone, which is salt retention and potassium wasting. So if they prevent potassium wasting, they're actually potassium sparing, and that's why they're often called potassium sparing diuretics. They're going to work right over here. They're going to prevent the effects of aldosterone, preventing sodium retention, and sparing the potassium. And this actually reduces blood pressure. One thing that you do need to know is that this is one of the drugs that decreases mortality. It's important to know the drugs that decreases mortality. So far we've covered beta blockers, we've covered ACE inhibitors, and we've covered aldosterone blockers. All of those actually reduce mortality. Now the adverse effects of these drugs is going to be similar to what you would expect from steroids, gynecomastia. So they're gynecomastic because they actually also block the androgen receptors, which are also intracellular, and they also inhibit androgen synthesis as well. So they kind of work on both ways. Here's what gynecomastia would look like. They may show you this picture over here, where you see a little bit of breast developing in a male. That's just because of breast tissue that's coming in from decreased aldosterone and taking over of the estrogen that is naturally produced in all of our bodies. Something else that they can cause is hyperkalemia. Remember, they are potassium sparing. So if you're potassium sparing, you do run the risk of having high potassium. And having a high potassium puts you at risk for arrhythmia. Calcium channel blockers are often tested as well. They're divided into two groups. There's going to be dihydropyridines and non-dihydropyridines. The way I like to remember it is that dihydropyridines work on the arteries and non-dihydropyridines work on the heart. Alright, so dihydropyridines are going to reduce the vascular peripheral resistance. Just think of it this way. We already know about this system over here with the G protein and that causes an increase in calcium through the IP3 pathway, and this increase in calcium will go through this path and then cause a constriction of it'll cause an inactivation of myosin phosphatase, and that causes a constriction. So since we already know that, and this constriction causes an increase in blood pressure, if you inhibit these channels right here, you pretty much prevent calcium from going into the arteries, and you prevent them from constricting. And that's exactly how it works. How you know that it's a dihydropyridine calcium channel blockers is that it'll end with dipene, i.e. dihydropyridine. Something you need to know is nifedipine is safe for pregnancy. Iodopine and felodipine is also a calcium channel blocker. Now, an adverse effects of them is going to be the peripheral edema and the hypotension. Peripheral edema, just think of it, your blood vessels cannot contract, so maybe some fluid can exit out of these blood vessels and cause edema. Now, non-dihydropyridine, we're going to go into more detail when we get into the arrhythmia module, but they work by blocking calcium channels in the heart, and they reduce the heart rate through this mechanism. We're going to go over it in more detail. The two drugs that you need to know there are going to be verapamil and diltiazem. Adverse effects being, of course, slow heart or blocked heart, i.e. very slow heart, or significant constipation. Now let's talk about alpha blockers. Alpha blockers are not often used for blood pressure, but they are often used for benign prostatic hypertension. Nonetheless, they are often asked because it tests your knowledge of the sympathetic nervous system. All alpha blockers end in osin. Tamsulosin ends in losin though. Now the mechanism is that they inhibit the alpha-1 receptor, and inhibiting the alpha-1 receptor means that you prevent the arterial tones from constricting and you prevent the prostate from enlarging. Something you do need to know is that tamsulosin has no effects on arteries. It only works down low, so that's how I remember it. Tamsulosin only works down low. Prazosin can also be used to reduce PTSD. So the way I remember that is that they both start with P, and I just remember prazosin can also reduce PTSD. The adverse effect is obviously going to be orthostatic hypotension because that's what happens when you take something that reduces your blood pressure. Now let's talk about beta blockers. They all end in lol. If they have an olol though, that means they're only blocking beta 1. If they have an alol or an ilol, that means they could have an effect on beta 1, beta or alpha. So something you do need to know with the naming system is that if they start with A through M, that means that they're aiming for the heart. That means they're cardioselective and they're safe for asthma patients because they won't affect beta 2, and blocking beta 2 causes constriction of your pulmonary pathway. If they are N through Z, if they start with N through Z, that means that they have beta 1 and beta 2, and they're bad for asthma. Something you need to know is an exception to this rule is carvedilol and labetalol. They are mixed, and what I mean by mixed is that they affect both beta and alpha. So carvedilol and labetalol will affect both beta and alpha, so I remember it by don't mix what you carve in the lab. To remember carvedilol and labetalol, and they are mixed. Now the mechanism is, of course, they block the beta 1, and this decreases the AV node and the SA node, and this reduces the heart rate. When you reduce the heart rate, you are actually reducing the O2 demand, so you're actually reducing the damage to your heart, and this has actually been proven to decrease mortality. That's important. It's often asked in step 1. The effects, of course, is going to be bradycardia, a slow heart, or an AV block, a very slow heart, or even heart failure. The heart's pretty much not working. So you got to be careful there with an overdose in case of a heart failure and AV block. Something else, of course, that you might be able to pick up on is sedation, because you're inhibiting the sympathetic nervous system, and sleep alteration. Something else, if it's beta 2, if it affects beta 2, as we've talked about before, it can be damaging to people with asthma or COPD. And it can also mask the symptoms of hypoglycemia. Hypoglycemia is often tachycardia and whatnot. So if you don't get the tachycardia, you may not know that you're hypoglycemic when you're a diabetic. All right, hypertensive emergencies, we have a couple of drugs for these, and they work really well and really fast. The first one that you need to know is going to be hydralazine. Hydralazine works by increasing cyclic JMP in the arteries, and it's important for you to know that it's affecting the arteries because it actually reduces the afterload. If you think of blood vessels being, here's the vein, and then here's the heart, and then here's the arteries, when you get a reduction in pressure over here, you're actually decreasing the force that is being that the heart has to push against, and that's the afterload. So you're decreasing the afterload. This is actually safe for pregnancy. Sometimes with pregnancy you get high blood pressure that can be dangerous, and this is actually a drug that is safe for that. It actually also decreases mortality when it's combined with nitroglycerin. We'll talk about that in a little bit in the case of congestive heart failure. It has a unique side effect being lupus. Lupus is just fatigue, joint pain, and butterfly rash from an autoimmune reaction. This autoimmune reaction can affect other organs, especially the kidneys. That's what we're afraid of. You'll learn more about lupus as you go through medical school. Moving on, let's talk about nitroglycerin. Nitroglycerin or isosorbide dinitrate, anything with nitro in its name really, has a similar effect to hydralazine, but it only affects veins. Here's how. It releases the nitric oxide, and nitric oxide increases the cyclic GMP just like hydralazine did, and this causes vasodilation, and it just releases it in the veins, and that's why you get a decrease in preload. Remember, preload is going to be the veins part, and if you get a decrease in preload, that means you have less blood going into your heart. So in cases of heart failure, for example, just decreasing the preload alone can actually be dangerous because it's kind of depending on the blood going in order for it to go out because the heart's just getting too weak to push it out. So that can actually be worse for people with heart failure. So just keep that in mind. Here's how nitroglycerin works, just so you can remember it. Here's a glycerin molecule or glycerol molecule with a lot of nitrates on it. So that's why we call it nitroglycerin. It's actually used in dynamite, and it's is the invention of a famous scientist called Nobel, the origin of the Nobel Peace Prize. All right, let's talk about nitroprusside. Nitroprusside is imaged right here. As you can see, it has a nitric oxide right here, which is released, and it actually increases the cyclic GMP in both arteries and veins. It actually does both. Now, something else that you may have noticed is that it also has a cyanide right here, and here, and here, and here, and here. That's really dangerous, and it can put you at risk for cyanide toxicity. Let's go on to the last one. This is going to be phenodolapam. Phenodolapam, it has a DO in its name, so I just try to remember it as D1. agonist, and this D1 agonist causes vasodilation, especially in the kidneys. They might ask you, like, this person has high blood pressure and he's got, like, kidney problems as well. This may be what they're looking for. And this helps with renal perfusion. Newer studies is proving that that might be actually be false, but up until now, just stick with just maintaining renal perfusion. So these drugs can actually be really important. They're very high yield and commonly tested, and they are even important for you to know the clinical setting for each one, like which ones increases mortality or decreases mortality. So something you need to know is Mona B in the case of the ER setting. If you see someone who looks like they're having an MI or a STEMI, then you want to remember Mona B. That's morphine, oxygen, nitrate, aspirin, and beta blockers. They might just ask you, like, what drug would you want to give them, and then you want to pick one of these over here. Something that you do need to know is that there are different drugs for different types of patients. If they have diabetes mellitus, you may want to give them an ACE inhibitors because it's been proven to be protective of their kidneys and increase their lifespan. Beta blockers may mask hypoglycemia, so you might not want to give that to someone who is diabetic. Something else is in cases of systolic heart failure, i.e. the heart is having trouble pushing stuff into the arteries, you want to give something that reduces the tension of the arteries. That is ACE inhibitors, beta blockers, aldosterone blockers, spironolactone, because they actually reduce mortality. It's been proven that they reduce mortality. So it's very important that you want to give these. In fact, a clinic that doesn't give these actually gets dinged for not providing the patient with an ACE inhibitor or a beta blocker. Benign prostatic hypertension, you may want to consider an alpha blocker. Even though they're not as effective, they may actually help you with two things in one, like a large prostate and hypertension. In case of pregnancy, you want to think of methyl-dopa, labetalol, nifedipine, and hydralazine. These are just a list of some stuff that are safe for pregnancy. And as for renal failure, like as in very severe renal failure, you don't want to use ACE inhibitors, you don't want to use ARBs, and you don't want to use diuretics because they may reduce the perfusion to your kidneys and cause more damage. Thank you.